It's my pleasure. I'm Vito Thrani, cardiac surgeon at Piedmont Heart Institute in Atlanta, Georgia, and it's my pleasure to co-moderate this with Marty Leon, obviously, who requires no introduction. And today, what we're going to talk about is something that's absolutely, revolutionized our TAVR program in Atlanta, and has really changed our outcomes and how we do stuff. And so we thought we would just jump right in, and the title of this lunch session is Enhancing Structural Heart Procedures Using Dasi Simulations and AI-Driven Prediction-Based Algorithms. AI is here, computational modeling is here, and we use it every day in our practice. So we're going to start it off with a couple of different talks. One will be by Marty on AI-driven prediction, one by Hassan from Cedars and by Cuspids, and then the TAV and SAV and TAV and TAV with Matthew Summers, and then lastly, how we integrate this into our workflow at Piedmont with Pradeep Yadav. So, Marty, you want to get started? Maybe say a couple of words.
Vino, thank you very much. Can you all hear me? Terrific. Well, this sound isolation business actually works. So we have kind of an open environment here, but I think we can hear each other well and communicate nicely. I was excited to participate in this because I'm a little bit on the outside. I learned more about Dasi from Vino and Pradeep and seeing what he's doing in Piedmont, and I became very curious. We've always been interested in image-guided therapy. We've always been interested in pre-planning. We've always been obsessed with the idea of identifying complications before they occur so we can get better outcomes in our patients. So for all of those reasons, and now with the new fever around AI, this became kind of a natural for me to get more involved in this, but I don't want to I don't want to suggest that I'm an expert at this technology, but maybe that's a good thing. We've had more selective applications at Columbia in particular cases, but the idea is, can we grow from that point to a much more systematic use under a variety of circumstances that's going to make our outcomes better? So I'm going to start with more of an overview presentation, and then the real aficionados are going to talk more about the specific areas that you should focus on. My disclosures, I do not have any relationship with Dasi, but I like the people. They're very, very easy to work with. They're very science-oriented, and the fact that they want to accumulate data and continue to improve is really consistent with the theme of what AI is. So I'm going to talk a little bit about what is the motivation for doing something like this concept of creating a digital twin and becoming interested in predictive modeling, and this whole issue of software as a medical device alternative approach. We do this a little bit at Columbia because we've spent the last 5 or 7 years with our bioinformatics people developing software algorithms to use 12-lead ECG snippets to make some diagnostic projections about patients who might have valvular heart disease. And we've learned of the power of that, but this is taken to a completely different level as it really gets integrated into image interpretation. We'll talk a little bit about some of the prediction model examples. We won't get into too much detail because individual speakers will go further on issues relating to coronary obstruction risk, something we're all very conscious of. Aortic rupture risk, which we don't see much anymore, but still is probably one of the most feared complications that can happen with TAVR. And getting into kind of the next generation, things like being able to predict valve performance post-therapy and linking it to what you can expect to see with an echo gradient after you've put the device in is very interesting to me and may have some real implications in terms of testing certain specific devices under specific clinical indications. So we'll discuss all of those things. So what is the motivation? I mean, TAVR is now done on over 100,000 people. It's a quick procedure. In most patients, we don't need very much of anything. Usually there's not an echocardiographer in the room, there's not a sonographer in the room, there's barely an echo machine in the room. 85% of people are not doing embolic protection. Very few people now are doing systematic transesophageal guidance. It's kind of an in and out 30 to 60 minute procedure. What's wrong with the current approach? In some respects, the simplicity of it is what's made it generalizable and why it's become so popular, and it's really revolutionized the whole space. But to a certain extent, I think it's created this elusive notion that we have all the answers and that all cases are easy. The reality is, as we go deeper and deeper, and as we really strive to get the most optimal outcomes, we can't do this very quick, one and done. We've got to be a little bit more planning oriented, and we have to use other tools that are available to us to both avoid the occasional complication and, more importantly, to treat the complex patients. So right now we do manual planning for TAVR to discuss treatment options, and that's usually CT based. We make manual measurements for each option. There's a lot of variability. When we have multiple people doing it, our fellows, our attendings, we get different outcomes, interestingly enough. And to be perfectly honest, 90% of the actual interpretation is done by sponsors and are given to operators. And that introduces a whole different level of bias. I don't want to get too far into this, but it's probably not the ideal way to do things. We make treatment decisions because we have a lot of options, but those are really not based on predictive device and biologic or organ interactions. The ability to differentiate treatment options is more intuitive, based upon experience, and not very analytic. I like self-expanding valves. My experience has been this. That works most of the time, but I hate to use that as the rule in terms of how I communicate with patients. The algorithms that have been developed have been based on average populations. And that's what's so different about this. This is patient specific. And the fact that it's patient specific means we can make statements about an individual patient, their anatomy, their clinical scenario, as opposed to quoting data from what are larger data sets. And we haven't had very good lifelong planning tools. I will tell you, some of the apps that have been developed by people like Vinny Boppet have really, you can see how they've really caught on in terms of being able to standardize the way we manage valve and valve and now TAV and TAV. So I think that the audience, the community of operators, is really interested in getting a more deliberate approach to how we manage patients. Now, these are old data, and this is a good friend, Nimesh Desai, who talked a little bit about the consequences of complications with TAVR. Now, for 80% of the operators, the complication level tends to be fairly standard, and you've got to get up to the highest 20% volume operators to really see much in the way of improvement in terms of reduction in major complications. So it means that the vast majority of the sites and the majority of the cases being done are done by relatively lower volume operators. The consequences of complications to the healthcare system, estimated by TAVR alone, is about $2 billion of additional costs, or $8,000 or more per TAVR patient, and 2 additional hospital days. So we always tend to minimize the impact of complications. And what these algorithms and this technique can help us with is reducing those complications. The concept is to create a digital twin paradigm for predictive modeling that requires segmentation of CT images. There's a lot of technical terms, convolutional neural networks. They train on sample sets, and they make automatic measurements, and then they display the software in a very physically appealing and visual form that helps you to make immediate recognition patterns to be able to identify what's important for a given case. And this is what's become a very interesting acronym, SAMD, which is Software as a Medical Device, and it is exploding, not just within cardiovascular medicine, but in all of medicine. So how does the AI work? Well, for each valve type, whether it's balloon expandable or self-expanding, they've developed proprietary models involving what's called a triangulated mesh model of each part of the transcatheter valve and of the anatomic substrate. So they look at the stent, they look at the native leaflets, they look at individual biologic features such as calcific nodules, the position of the coronaries, the size of the coronaries, the aortic root. The model is trained on a training data set composed of pre and post CT images, and we've got to thank Piedmont for providing a lot of those images to help that training process. But that's an ongoing event that will continue to improve the models, and it helps you to develop new terms that we use, like the stent tissue deformation assessment. And you'll see how that affects your ability to establish predictive modeling for specific situations. One of the main reasons for doing this initially was to see if we could accurately predict what the scaffold or frame would look like after you did a TAVR. So a lot of the original models that were submitted to the FDA for validation data were based upon predicting the balloon expandable waist size or the self-expanding waist size. They've also looked at things like self-expanding radial force, and they are surprisingly accurate with less than a 10% geometric error in predicting frame and anatomy deformation, and that spans a whole variety of different morphologies. So those are some of the things that they're particularly good at doing. Coronary obstruction has been one of the key areas that people worry about. Certainly as we get more involved, we do a lot of valve and valves, but now TAV and TAV, it's become more of an issue. And the metrics that we use now that are CT based are good, but they're not great. This is beyond good. And this is it's an interesting case example of a right coronary artery that was, the height of the origin was over 11, yet this case resulted in compression and occlusion. And Pradeep apparently got very upset about this, and this became kind of a test case to say, can we do better, and can we predict the cases, frankly, that would have suggested that they would get a good output, a good outcome. So they've developed a predictive model, which you're going to hear about, so I'm not going to go into great detail, that would allow you to use this to get a much more refined taste of whether or not you have a likelihood of coronary obstruction. They looked at a clinical data set at Piedmont of over 1,500 patients with just under 10% that had increased traditional risk of coronary obstruction, and it was surprising. Many of the cases that were high risk for coronary obstruction, they were able to do TAVR with good guidance and with some adjusted techniques. And it was interesting that many of the low-risk patients fell into a higher risk category when they applied systematically the Dasi algorithms. But you'll hear more about this. To me, even more important was the issue of predicting rupture or injury. This is still a little bit of a work in progress. We do this, what we do is we do transesophageal echo. And if you have Becky Hahn in the room, it's like having a Dasi because she can see things that most of us can't see. But that's not generalizable. The idea of being able to see how the root tissue stretches, to see how a calcific nodule is going to affect the likelihood of developing a root rupture is really key, and it really helps you, I think, to develop your procedure algorithm. On the newer side, this idea of predicting post-implant gradients in both tricuspid and bicuspid valves, applying these deep neural networks that are trained on pre and post Doppler waveforms from echoes is really fascinating. And they've really developed some interesting opportunities to be able to predict what the post gradient is going to be depending upon the valve type and the anatomy. And I think that's very helpful. If you're going to decide you want to treat a small annulus and or you're doing a valve and valve and you're really conscious of what the hemodynamic outcomes are going to be, this kind of algorithm I think could be very useful. So we're talking about developing the kinds of software that can both predict complications but assist the operator in terms of specific decision making. This is just some of the work that's been done. I don't want to get into, again, too much of the specifics. They also have a fascinating algorithm which is complicated enough where, frankly, I can't completely understand it. I'm sorry, Pradeep, but it's a little bit beyond me now, and I need to get closer to this. But they have a way of predicting halt, which is also interesting and would be important because that might help you to stratify certain patients that you might want to get a CT scan post, or you might want to treat with systemic anticoagulation if the gradient begins to nudge up. So a lot of different things here. So just to conclude, we're on the threshold of developing these kinds of software algorithms and AI-directed digital twin models to be able to really have an impact on how we manage patients. And that's really what Dasi provides us with. There are other software approaches to this that are being developed, FIOPs from outside the United States. There are several others that people are looking at. I think that Dasi is really far along in terms of developing something that is clinically useful, that's been validated now on enough patients for me to believe that it can be used systematically, that hopefully can can guide operator decision making and prevent certain complications. And by the way, it's even reimbursable. So I'm going to stop right there and turn it back to Vito.
Yeah, great. Thanks so much, Marty. Also, if any of you in the audience have a question, please just raise your hand. We'll bring a microphone to you so that everybody can hear. But thanks, Marty, for a great overview of what's going on right now. Marty, do you want to introduce Hassan, and then we can keep going?
It's always a pleasure to introduce Hassan. Hassan is one of my favorite people. He is truly a scientist and an imaging expert. And he is obsessed with bicuspid aortic valve disease. He's developed some of the CT categorical systems for identifying bicuspid disease. He's now applying some of that experience now with the Dasi software to see to what extent, in that population, we can achieve a better understanding of how to approach patients. So Hassan, take it away.
I do also, Marty, want to mention there are three panelists that have joined us recently. It's Raj Makkar, Dr. Dasi, and also Pradeep Yadav. So you'll see them on the panel also. Sorry, Hassan.
Thank you. Thank you, Dr. Leon, distinguished panel, ladies and gentlemen. So these are my disclosures. So we know from, this was research performed at Cedars-Sinai, but a multi-center study led by Sung-Han Yoon and Raj Makkar, when we looked at the risk. So the TAVR risk is a concept that's developing. It's something that we all talk about in our heart teams, where we try to evaluate with piecemeal evidence base that different parameters can predict risk. So we have this concept for the aortic valve complex and CT predicting PVL, root injury, coronary compromise, and pacemaker, all have established CT-based predictors. We know from this very important research that a combination of a calcified RAFI and excess leaflet calcification result in dramatically elevated mortality, but it's still difficult to provide a patient-specific quantification of risk. So patients with high TAVR risk BAV phenotypes can still achieve very excellent outcomes with procedural modification in experienced centers and in experienced hands such as our own. This is a case done by Raj Makkar with a double tap approach. CT risk phenotype was high, as you see here, with a calcified RAFI, calcified leaflets, and a double tap approach can be done. We're very maximalist in this case. This is TE, as Marty mentioned, where you can actually see bulges as initial deployment -4, then post-still -2. So it's a maximalist approach, and good circular deployment can be achieved. But there is a need for reliable, evidence-based, quantifiable biomarkers that can quantify risk from different approaches in an individual patient. So Dasi digital twins have the potential to provide this generalization of precision medicine-based approach to test multiple options in a specific anatomy. This is a case we looked at retrospectively with Dasi. We do several very highly calcified valves at Cedars-Sinai. This is a case with severely calcified RAFI, severe valve calcium, but also commissural calcium. And not only the quantity, but also location of calcium was important, and the directionality of expansion is relevant, but some of these are difficult to predict. Some cases go well, some cases not so well. So we're looking retrospectively at how Dasi can improve. So we looked at this. This is a reduced order model, as Marty mentioned, where the stent expansion is very accurately predicted, but also the neighboring structures. And often on TE, we see these kind of bulges where we saw this displacement in this case retrospectively. And the maximum stretch of 1.9 is really very high in our limited experience looking at this parameter. This is a case but with a large annulus, similarly severely calcified, but weighing the size of the annulus with the extent of calcium often is very difficult to objectively collate this information. This is a case that did very well at Cedars with -3 inflation, and we looked retrospectively even at +4, but the fact that there's not only severe calcium but also accommodating large annulus, the stretch, as you see here, was really very low. So we're starting to understand the relevance of that. Interestingly, in this case, we did still see a waist, and we saw halt. So this is something, as Marty alluded, is very interesting and potential application of Dasi. So this was commissurally misaligned sapien, incomplete expansion with mild eccentricity, and halt in the non-right cusp. And we had data, this is data from CEDARS, with over 200 patients pre and post CT with bicuspid valves. And the presence of eccentricity and under expansion actually results in dramatically elevated halt. So you go from less than 10% halt to 60% halt if you have this combination. So this is really very important to predict this parameter. And Marty mentioned the normalized circulation. So we're starting to look at this with cases using Dasi, this normalized circulation model. And it's based on engineering principles to rapidly derive data using only baseline CT with baseline echocardiogram. And you can perform these geometric predictions. These are simulations, but essentially the more normalized circulation with this biomarker, the less the thrombosis risk, and the lower the normalized circulation parameter, the increased thrombosis risk. And misalignment is associated. So we looked at this and we blinded the Dasi team to two cases, one with quite a substantial waist and one not so substantial waist with bicuspid. But it's much more complex than just having a waist and not a waist. And this influences decision making, especially in the presence of calcification, where there could potentially be harm for aggressive post-dilatation. So looking at this parameter in these two cases, we interestingly found, despite the waist, a better circulation, so more normalized, higher normalized circulation parameter in each of the leaflets. And we saw no halt in this case, and we saw 2 leaflet halt in this case, despite having less of a waist. So it's a little bit more complex than waist, no waist. So in conclusion, optimizing TAVR in bicuspid patients with Dasi, bicuspid anatomy and patterns of calcification are highly variable. Not only sizing and calcium quantity, but also location and directionality of displacement are highly relevant to complications such as root injury. And the competing risk of complications exists on a specific patient. So overinflation can lead to root injury, but under expansion can result in thrombosis. So Dasi digital twins offer considerable promise in summating all these complex factors collectively and testing multiple approaches in a specific anatomy. Thank you.
So, Hassan, if you want to just stay up there for a second, maybe we have some time for discussion at this point. What percentage for you and Raj at CEDARS, what percentage of your patients are you doing bicuspid now? Are you seeing a higher rate of bicuspid TAVRs that are being done? And, you know, and just tell us about your practice right now.
And let's put that in some perspective before you answer. If you look at the TVT registry, it's about what? It's 6 or 7% of the total TAVRs?
Of 100,000 patients.
Of 100,000 patients.
Right.
So that's kind of what's done nationally. And if you look at something like the early TAVR trial, which is the first time we could do bicuspids, they were allowed to be included. They were 8% of the patients. And in some of the European trials, it's also been in the high single digits. So now tell us what you're doing at CEDARS.
So that's, let's just say it's 10%, right, nationally, somewhere around that. CEDARS?
So I think Raj would perhaps better comment, but we have more than 600 bicuspids now, and every week we're seeing more and more.
I think...
Turn your microphone on, Raj.
So yeah, we have a little bit of a lower threshold than others in terms of doing bicuspids, and I think also we are getting ready because we want to do a large randomized clinical trial, and we want to maximize our experience and learnings. So I think that it is fair to say that maybe 12, 13, maybe even 14% of, lately, of our cases might be bicuspid. And the reason why I'm excited about this technology in bicuspid and why Hassan and I often talk about this is we did the initial work, which was very, I don't want to call it primitive, but rather simplistic. All right. So I think, just knowing the volume of calcification, the amount of calcification, whether or not a raphe is calcified, it sort of gives you a very simple method of looking at things, but it is too simple. And I think in real life, the anatomies are a lot more complex and a lot more heterogeneous. So we need to have a better way. And I think that is true not just for bicuspids, but I think even for tricuspids. So I think we need to go to the next level. And I think that is where probably, and we need to develop this technology. This technology will only keep getting better if we feed it more cases. So
it's
I
a
think,
hungry computer.
Exactly. So I think that is why we sort of need to help develop this, because it's a very valuable tool.
So Pradeep, I'll have you come in also. I would also, Raj, say that Pradeep and I do a lot of bicuspid cases. I will tell you that the bar is a little higher for bicuspid because there tend to be a little bit younger patients. And our results have to be just as good as surgery. As a surgeon, I can say that. Because if not, then you've done the patient a disarm. I'm not talking about the patient with a big aneurysm. Pradeep, tell us kind of what we're doing at Piedmont.
100% agree. And our number for bicuspid is definitely more than 7%. I don't know what exactly it is, probably low double digits. We do have, once again, complicated case. Let's say a CT looks concerning, heavy calcium burden. You don't know how the raphe is going to split. Before deciding which way that patient goes, we'll send it to Dasi. And it's been so reliable in the last 4 or 5 years. We know you can comment on these star 3 ratings better than me. We are a star 3 program, very low complication rate. We have a lot of bicuspids that we do, which visually on CT through Mencio, you would never do it. And not just doing the case without a complication, but optimizing your procedure also, I think, is important. Yes, you can do a case with leaving 2 cc's, 3 cc's behind and get away, but that's not the right thing for that patient. So simulations do help in optimizing the valve implant as well.
And you'll talk about this a little bit later, but it actually, we now have it where we discuss it with the patient, and it has allowed some patients to get a TAVR done where they otherwise would have had surgery or vice versa. Hassan, kind of last comment on bicuspids before we move on? The field of bicuspids?
I think it's rapidly evolving. I think there are multiple new devices that can potentially make bicuspid safer, and I think it's just in very, very experienced centers. I think Dr. Leon touched on it in his presentation. The majority of TAVRs are done in lesser experienced centers, and the challenge, having a case done at Cedars-Sinai or Piedmont, many difficult cases can be done very safely, but it's understanding the risk in an individual patient where potentially a lower volume site may not want to do such a case.
Okay, great, Marty. You want to introduce Matt?
Sure, yes. Our next topic is this exciting new area of TAV and SAV and TAV and TAV using Dasi, and we're very fortunate to have Matt Summers from Centera, who's an extremely high volume operator who's really come to the fore as a leader recently. I will tell you the predictions of TAV and TAV that I thought were a little bit grandiose are coming true. And that by 2028, at the very latest, the number of TAV and TAVs will exceed the TAV and SAVs. So these numbers are increasing quickly, so we better get our arms around how to do this best.
Yeah, thank you. Thank you for that introduction. As you mentioned, we're working in a high volume center where we're increasingly tasked with trying to sort through the 499 patients that aren't going to have an annular rupture and defining the one per year that is, and also predicting low frequency events like coronary occlusion. And so we linked up with Dasi a little over a year ago and have been using them uniformly in all complex cases, which we took your lead from Piedmont, almost all valve and valves, high calcium scores, younger patients where we're worried about lifetime management, hemodynamics, hopefully in the future. But we're also in a position where we're trying to individualize therapy for those 500 patients. We have, at our discretion, all 3 commercially available valves, and we're trying to make very individualized guesses and estimations of which valve is going to serve best for each individual patient in a high volume center. And so we found it incredibly useful for individualizing therapy in structural heart. I brought two cases that highlight what is strongest in what we've seen its largest strength in, which is predicting coronary occlusion, and that highlights sort of what we're seeing more and more frequently within structural heart, of these complex cases where we're having to make decisions about leaflet modification. So this first case is a 70-year-old female that came in with a degenerated bioprosthetic valve that was put in 2013, had a concomitant aortic repair, multiple PCIs, and then was a TAVR candidate then because of severe COPD, and came in with obviously progressive bioprosthetic valve dysfunction, stenosis with class 3 symptoms. This is how we look at patients right now. So this is how everyone has done this for predicting coronary occlusion historically for years. And ultimately what this is, and the difference between this and what we're able to accomplish with Dasi, is that these are just drawing circles on top of a CT scan and taking measurements that have a lot of variability, as was mentioned. By these numbers, we had some concerns, mostly because of the left height. The VTCs and VTSTJ were a little bit more reassuring. But this is a case that highlighted sort of what we were up against as far as coronaries, and something that we would have potentially not been as keen to address were it not for more sophisticated modeling. And so on this, choosing between the two valve platforms, we saw that the balloon expandable 23 valve was going to come with a considerable risk for right coronary occlusion. And that risk wasn't present with self-expanding valves, but we were planning on fracturing the valve as well because of the small size. And so a combination of both of these, looking at the coronary prediction, occlusion prediction, and incorporating what we plan to do with valve fracture, led us to make the decision about leaflet modification. But you can see how just visually this allows you to understand commissural alignment and its importance, sinus sequestration, coronary occlusion, and why it functionally happens. I think fundamentally, compared to looking at CT scans and multiple planes, this allows us to visualize the problem at hand. And so this is the two valves that we were choosing between, and we make preferences for valve and valve hemodynamics, and so chose an Evolute. But because we were planning on fracturing, we were going to do leaflet modification as well because of that prediction with the balloon expandable. So this is a cleave procedure that you can see the low right coronary height. It's a 7 French AL1 guide and a 4020 charger with the back end of a J, 70-watt cut. You can see in 3D multiplanar, us perforating very cleanly through the base of the leaflet. We inflate that balloon and then use it anchored to exchange for a Safari. We balloon that perforation with a 12-millimeter balloon and then deploy the valve inside of that. The patient is stable through all of this, and then we dilate the valve, and then, as you'll see, we fracture the valve as well. All of these are guided in our center by 3D MPR, at least leaflet modification. I know that's not absolutely a necessity, but we find incredible value in making sure we're at the correct portion of the leaflets and perforating the correct portion of the base of the leaflet. And afterwards, we had a no PVL and a peak-to-peak of 4 that matched our TE gradient and was deployed exactly where we want it to be. So that's a case where we potentially would have had a right coronary occlusion if we would not have done Dasi. And so it's helped us identify cases, but it's also helped us avoid cases. The second one that I want to show briefly here is a redo TAVR. And so this is an 86-year-old female. And again, this highlights how we historically have looked at pre-planning and sort of how we've transitioned to planning, at least at our center, in the past 5 years. So this patient had a 23S3 in 2018, has AFib, and had 6 months of progressive symptoms. This is how we looked at things back in 2018. At the time, she had an annular area of 391, but relatively narrow sinuses that were of concern for self-expanding valve platform. Coronary heights were technically above 10, but borderline. Made a decision to put in a 23S3, and she came back now 7 years later with bioprosthetic valve dysfunction and stenosis, class 3 symptoms. This is how we look at things now. Again, very much the same fashion, drawing circles on top of CT scans and what we have called before predictive guessing as far as what's going to happen. But there's considerable concerns here, mostly in sinus sequestration. As we blow that up, you can see the frame of the S3 comes above the left main, but also the leaflets obviously don't come up that far. But we're walking a very narrow line here between coronary occlusion or not. You can see a lot of this calcification at the superior portion of the right coronary artery as well. We had a lot of concerns about coronaries here. And so overall, Dasi showed us that with a self-expanding valve, we may have some reassurance with a slightly lower implant. But we still had questions looking through all of these, even outside of the AI predictive models, on whether we would have the skirt of the Evolute counteracting the S3 cut, and whether this was a prediction that would be accurate given its novelty. We ultimately ended up doing a double shortcut in this case. You can see highlighted through here that procedural process, which most folks are familiar with, but we ended up making a decision for leaflet modification in this case because we were concerned about sinus sequestration in particular, really wanted commissural alignment in that case. But in conclusion, I think computational modeling and these advanced simulations give us more precision at a large volume center, and even across the country as more and more TAVRs are being done at lower volume centers. This is a potential way to find those cases that can get drowned out by all of the 30 to 45 minute TAVRs that uniformly do well. We get better visualization and planning for complex problems like sinus sequestration. I think fundamentally as an operator, I understand why the problem occurs more frequently now. And so in the past year, we do about 10% of our volume of valve and valves or redos, so about 50 cases a year. And in 2023, we did 27 leaflet modification cases. We incorporated Dasi, and we're researching this right now, but we did 7 cases last year. So we've been able to reduce the number of leaflet modifications that we've done from 27 to 7 just by incorporating more advanced, more precise pre-procedural planning. Thank you.
So, Matt, that was a great summary on that. I mean, we're seeing a lot more of these patients come in through, not just surgical valves, but also catheter valves. Explain to us, and a younger patient, 62-year-old comes in for whatever reason, this patient is going to get a TAVR. How are you, or are you using Dasi, to plan for that future TAVR down the road, or a, either self-expanding, or how are you doing that? Can you just explain that to us? Are you using it just for this? Or are you using it in addition for lifetime management?
So the use for coronary occlusion, I think, is the strongest right now, but we have used it, taken you all's lead at Piedmont with younger patients, bicuspids, patients that were worried about having needing a 2-valve strategy for lifetime management. Where we found that particularly helpful is Dasi will model the initial implant, and they'll model the redo TAVR at different nodes of implant. And so we can actually, as you were talking about discussing with patients, we can show them what an upfront SAVR may look like as far as risk, and we can show them what an upfront TAVR may look like as risk, not for their index procedure, but for their future procedure. So it's incredible as far as individualizing the therapy, not just for the procedure at hand, but for their future procedures. So we found it incredibly beneficial there too.
And then maybe going back to Raj on this, just tell us your state of thinking for higher imaging needs for TAV and SAV. Like us, you do a lot of these. And first of all, where's that field going? Are you seeing a lot more patients like we asked you for bicuspid, and where you think further imaging is needed for this?
So I think redo TAV specifically, and of course also, TAV and SAV, they are 2 very good indications for this technology. So I think we really need, especially, I like Vinny's app, but I think things can be much, much easier with simulation here. So, and I think they can be much more efficient and probably even a lot more predictable and a lot more accurate. So I think it takes the person who's analyzing almost out of the picture, because this is actually being done by the professionals. And it is displayed in a very simple fashion for you to actually see. So I think that's the other thing. So,
are you seeing an increase in these patients? Are you seeing more? Are you seeing more TAV and SAV now, or TAV and TAV?
We are seeing, I think what we are seeing is an increase in the number of redo TAVRs. But of course, there's always a fair number of
redo surgery.
So I think these are going to be very fertile areas for the use of this for the use of this technology. And I think we just saw 2 case examples. And I think that what I just heard, that you were able to actually change your strategy, and rather than, do something, modify that, avoid leaflet modification in some and use it in others is also very, very helpful. So I think we are going to see more and more of this.
So I'm curious in the audience, how many people are currently doing leaflet modification work? I just raise your hand. Okay.
Maybe ask the question, how many of you like it or love it?
How many
Probably
people
nobody.
love doing leaflet modification?
At least our own incidence of leaflet modification has gone down ever since we started using simulation, because those traditional numbers that we know, risk planes and from the apps, those are not patient specific, right? I mean, that VTC or 4, it may not be applicable if somebody who has tight STJ, right? So the advantage of this software is that it's very patient specific. Where was that first index THV deployed? Was it deployed low? Was it deployed high? How much of the calcium burden is in the leaflets? So
I think whenever you have to use a bovie and you're a structuralist, then you're not really excited about the procedure.
But I have to say that
Other than a transeptal puncture.
Yeah, but I have to say that I have become a lot more enthusiastic about leaflet modification with the dedicated shortcut device. And I think that I don't think the goal here is to exclude leaflet modification, is to see how you can end up with the best possible outcome, because, the rates of fracturing these valves in our practice have gone up since we've actually started using leaflet modification.
Yeah, no, I agree with that. I think we've done about 6 or 7 shortcuts now. Mm-hmm. So that has made it a lot easier for us, Raj. We totally agree with you.
Okay, we should introduce Pradeep, but I'm not sure that we need to introduce him.
yeah.
He is the structuralist who leads the program at Piedmont, who's really come to the fore over the last several years. It's a combination of his humility, his academic rigor, and his, procedural capabilities, which are extreme. And he's been using a lot of new technologies, and he's going to talk more about how you integrate AI workflow into a heart team approach, and how do you make this something that you can actually do that, has reasonable reimbursement and is worth the time.
Thanks a lot, Dr. Leon. I'm basically Vinu's assistant. He tells me this is the
That's
vision.
such bullshit.
No. He just says, we need to do this, operationalize this. We need to figure out a way how to get paid and how to incorporate in our workflow. So what is a usual TAVR workflow at most places? You get a TAVR CT. It's measured by either your fellow, yourself, your imager, your radiologist, company reps. Somebody will measure that CT scan, and then most programs will have a multidisciplinary meeting. You'll look at those images, you'll make a decision. And if it's a good anatomy, great case, you'll move forward with the procedure. And if there are still some concerns, then you'll say, well, that coronary doesn't look nice. Let me just replay with the CT later today. I'm just going to measure it myself and just come back with the decision making. So that can sometimes delay your workflow. We keep Dasi simulations within, can everybody hear it? Because my audio goes up and down. Okay, so we, in parallel to getting that CT measurement at your own institution, we incorporate Dasi simulations in parallel at the same time, and that will hopefully eliminate this extra step of going back in higher risk anatomies. So which patient do you get simulation? We had to start somewhere. So 5 years ago when we started partnering, we started with high risk anatomies. Let's take the ones that we're struggling to make a decision. If you're looking at a CT 3-Mensio report and you're like, I don't like that coronary height, I don't like that calcium burden, it's a rupture risk, then let's start there. So we took the highest risk patients and started mainly looking at coronary occlusion and sinus injury, and eventually lifetime management became popular and we started looking more into that. So our criteria right now is that all valve-in valves, these are somewhat higher risk cases anyways, and those are tough to examine yourself also. Where is the risk plane? How do you have a gap between the stent frame and the STJ? Those are tricky measurements. So all valve-in valves, all bicuspids, anybody who has a high calcium score, you can define high for your own team, but somebody, let's say 3,000 or more, that's a significant calcium burden. Those will automatically be sent. Any red flags, any decision making you're struggling, LVOT calcium, those will automatically be deferred. And then lifetime management. Recently, we've introduced this. Anybody younger than 75 who's likely going to need a second prosthesis, maybe we should look at them and carefully implant the first prosthesis. So currently, a third of all our TAVRs are getting simulations, and we're making decisions based on those. Yesterday, somebody was asking, like, how often of those 1/3 patients are you actually changing your strategy? Well, it's not just changing the valve size or SAVR versus TAVR. It's also optimizing your implant. If we can look at a simulation and get a little more confidence that yes, in this calcified bicuspid, we can afford to go a full nominal volume or post-dilate the valve, that's going to lead to better long-term outcomes rather than leaving that under-expanded frames. So a lot of times it does change your clinical decision-making. So two of our valve coordinators are here in the audience. They do a phenomenal job. Automatically, when they get a CT, anybody who falls in these criteria is referred to the simulation team. We upload the CT to them, we get a report, and when we're having a multidisciplinary meeting, we always start off with these simulation cases. And then we'll make a joint decision whether this patient goes to surgery, a transcatheter, which valve type, and what technique are we going to use. So this is probably the most important slide of this whole thing that you want to take a picture of, because that's what your administrator would want to know. How do we get paid for these things? What mechanism needs to happen behind the scene? This is not a clinical info. This is more for your administrators. This is a workflow similar to what HeartFlow does. So once a TAVR CT is performed, your coordinator will have to place an order in your Epic or whichever EMR you're using to get a CV TAVR 3D simulation. And if you don't have this order inbuilt, your IT team can help create that order. Once that order is placed, Epic will notify your CT department that there is such an order for simulation. That CT department will have to create an appointment and request pre-authorization. Once they get pre-authorization for that simulation, the CT department will notify the tech to complete the exam. Basically, you open the exam and you close that exam after getting pre-authorization. Once that encounter is open and closed, it notifies your valve coordinators to go ahead and upload the CT to Dasi simulations. So this is the process that happens for HeartFlow and CTFFR also. So this needs to happen behind the scene if you want to get paid for this. Due to the nature of code, appointment must be scheduled at location where CT was performed. So keep that in mind. In the last 12 months, we have submitted around 250 CT scans in our institution. Only 2 rejections for pre-authorization. And we were very careful when we launched it. We were getting quarterly feedback from our finance team that you're doing okay or you're not doing okay. And so far, we've only seen 2 rejections. This is a typical example that we are seeing of a failed Evolute and got simulations in this. Just looking at the Tremencio, we are very concerned about both the coronaries. But here, if you look, the ratio of 0.85 in the right means that it's in the gray zone. Even if you deploy a valve here, the right may be okay. It will be okay. Anything less than 0.7 is worrisome. But the left is clearly problematic, and you do need to do the left. Looking at the Tremencio, we were worried at both. But you look at simulations, your work got just reduced to half. You just have to do 1 leaflet modification. We were using a shortcut device, so we ended up doing a bilateral just because of ease of use, with the understanding that if we spend too much time in the right, we're going to abort it. We're not going to do the right. We'll just keep moving. Did bilateral split and place there. So in our experience, we have not had a sinus injury in the last 5 years of using these simulations. There is no unexpected coronary occlusion in 5 years. Incident of leaflet modification has at least halved, if not less. We're much better to prepare the complex cases. We're more likely to do a TAVR than defer. And some of these patients appropriately go to surgery, and that helps with patient discussion as well in showing them these slides that why we're recommending a surgery in an 80-year-old orthopedic surgeon that we did the other day. Like, look, this is not good for you. So I think no doubt better preparation will lead to less complications.
Great. Thanks, Pradeep. So maybe, Pradeep, you can stay up there a little bit. The other thing that we do that I just wanted to mention also is that we incorporate this into our EMR. So under the media tab of Epic, the PowerPoint slide, because let's be honest, we do our valve team meeting on a Thursday, but we may not do that TAVR for another 3 weeks. Well, how are we going to find that? That becomes really hard for us to do. So the PowerPoint presentation that's actually presented in our valve team meeting by the Dasi team sits in our media tab under TAVR simulation. So the day of the procedure or the day before the procedure, we can just go under the media tab, go to TAVR simulation, click it, and the entire PDF PowerPoint slide that has the videos in it pops right up for us to look at. So you can look at the night before, the next day. So that has been great for us, because otherwise we couldn't find it. And I think that maybe as it moves to an app-based program, that which is being developed by Dasi, is that you'll be able to do it on your phone, put in your patient's MR number, and all of a sudden the PowerPoint presentation comes up. Until then, we'll have these type of modifications, and so it's been pretty life-changing for us as far as our program. We do about 600, just north of 600 TAVRs a year.
I was going to say, this is one of those things that if you get used to it, you will never walk away from this.
Yeah.
Even our reps, when they come in, Edwards, Medtronic, or Abbott reps in a complicated case, they actually look for the simulation just for that extra safety, because assessing some of these complicated cases are anybody's guess.
Yeah, and quite honestly, our valve coroners and Kyle, Melinda and Martha, who are here, really do, quite honestly, they should be giving these type of talks, not us, because they do most of the work. Yeah. We just do the implants like monkeys. Mm-hmm. Maybe we could go to the panel a little bit. Matt, how have you incorporated this? And Raj and Hassan, how will you plan to do it? And then lastly, obviously, Prasad, maybe you can just make some final comments. Yep, Matt?
So the first year we used it discriminately like you all do, and took your lead just in more complex cases. But starting next month, we'll use it uniformly in every single patient, adapting a lot of the protocols that you highlighted here. I think we're using it also for the future plans of how this model is going to get better and better. And again, with the hope that we're going to be able to make individualized decisions about valve disposition, surgery, which type of valve, and not just risk mitigation. But we're planning on using it on every patient.
I have a question for the man, for Dasi. So, with the improvement in AI, where do you think this will actually go? What are the enhancements that actually we'll be able to see in the clinic?
Absolutely. Thank you for asking that. We are so excited about the future. I mean, this is only the beginning. Why would you not want to go into the OR already knowing what the gradient is going to be, already knowing whether or not there will be valve thrombosis in the patient? But where this will go is beyond just TAVR. We are already working on a model for TTVR with the Evoke that's already commercial right now, TEER, where you really want to put predictive models in the hands of physicians so they can know ahead of time what's going to be happening and have the discussions with the patient to make the right decision. So with the advances in AI, data science, etc., I feel like the sky is the limit, Raj. And thanks to the speakers today for believing in the future, adopting such a new technology already in your practices. We are really excited about bringing this to everybody here. So just feel free to reach out to us if you have any questions about how to access this technology.
So Pradeep, one question about this. There's a credibility gap. Until you use it, and you have case examples where you really think it's made a difference, it's hard to overcome what will be, at least in the beginning, some cumbersome workflow issues that have to be worked through. What level of user interface, when we look at a CT scan, we can do the measurements, we can scroll, we can do a lot of things. What level of user interface is there with the images that you get back, and is that a good thing or a bad thing?
So there is really not much you can do with those images. It comes as a PowerPoint with all the numbers written, so you basically are just making decisions based on that. You cannot really play with the images right now. Maybe the app in future will be able to move the valve up and down and change the numbers. Right now, no. That's
what I was going to ask.
Yeah.
Wouldn't that seem to be the kind of thing that you'd want as an operator?
I personally don't want to, because if you're doing 600, 700 cases, you don't want to play with this. You want something that is reliable, that is you totally trust, that is reproducible and that everybody can easily understand and follow.
So I think one of the things, Marty, when the procedures all started or the simulations came to us, it was actually didn't have -3, -2, 90%, 80%, and 20, and so we actually would give feedback and say, we need to know. It would just be Sapien 23. We're like, well, we're going to do a Sapien 23 plus 2. Go back and redo the algorithm. So we're always going back to the company because it's a small startup. That relatability and what Dasi can do and his team can put together with Terry, I think those are all things to look at. And I think that's a great interaction we should have with the company. They're always open to hear about it. They're all engineers. And so they want to make it better. So that's something we should think about, right? How do you make that? Pradeep and I, we don't have residents. So it's just the two of us and Jim and Vivek and Mark. But there are going to be a lot of places like yours where you have residents, you have fellows where maybe that would be beneficial for them to do. Maybe not for the two of us, but other people may have that.
Even in the report today, you have that ability like, okay, if you deployed node 4, this is what your numbers are going to look like. If you deployed node 5, this is how your numbers are going to look like. So some degree of information is already there. This is what you would do anyways, even if you had the user interface.
Great. I think we're right on time. It's 12:59. Any burning questions from anybody in the audience? Yeah. Here, I'll bring it to you.
Fantastic presentation. We just started to use Dasi in our workflow too, so we have been very impressed. The question I have is, as it is evolving, one of the gold standards, especially with Martin Leon here, is randomized trials, meaning predictability of holds. So is there any desire to develop a prospective clinical trial where incorporating Dasi may have better outcomes compared to doing a usual approach?
We know that's a question for you and Dr. Leon.
Yeah, so I would say that if somebody in the audience has about $50 million, we'd love to do something like that. I think that you could try to do that. I think it's you could try to randomize that. We talked about that a long time ago. I think that would be the proper way to do it, but I think the cost really becomes prohibitive to try to put something like that together. NIH would be a great way to send that through. As you know, they're in a free fall right now. And it would require something at a very high level to be able to do that. Marty, what are your thoughts on that?
No, I think you're right. The imaging studies are difficult to do in randomized trials. I think we need more experience. The worst thing you can do is to randomize too early before you know enough what you're randomizing, what the endpoint should be. So I think that we need a little bit more experience. And I think over the next several years, we'll be able to frame the questions more specifically. And then I think you can come up with a trial design that might be more reasonable. And then I think because right now we're at an inflection point. I mean, you have the zealots who are beginning to do it. And now you're going to see that probably expand dramatically. And once that expands over the next couple of years, then I think you'll get a better understanding about exactly what questions to ask. And I would subject it to a clinical trial environment just to see if we can prove that it makes a difference.
I think that we are already incorporating it into other randomized trials as the standard. For instance, the Myers trial is the trial is already using it. So it may be that we get core lab adjudicated data coming through us through other trials. So, great. Thank you for all the speakers. Thanks for the panelists. Thank you, Marty. Yeah.